Okay, starting part B of chapter 5, a lot of this section today is going to be dealing with the kidney, the renal side of the equation when it comes to controlling hypertension, and that means diuretics. What we're going to do is modulate the function of the kidney, particularly the tubule. We're going to talk about the renal tubule in order to promote the removal of fluid from the body. Most of us will probably have an understanding that diuretics are designed to make us remove more water from the system. It is promoting the excretion of water, part of the way that we can reduce fluid. And by reducing the fluid, we reduce then the amount of volume inside the blood plasma, which reduces pressure, and so less stress and strain on the cardiovascular system. That's great from a general perspective, but again, we need to be able to predict potential side effects. And by understanding a more refined approach, that's how we're going to get there. So what happens is we filter about 20% of the plasma volume that comes through the glomerulus. And that filtrate is full of things that are actually useful for the body. And so a lot of what's going on in the tubule is reabsorption of that material. Water-soluble material, ions, and so forth need to be reabsorbed because we use those things. We also are going to do some secretion as well, but in this case, what we're really focused on is reabsorption. The reabsorption of sodium and potassium and other things that are useful for osmolarity and plasma membrane voltage, among other things. So without diuretics, what happens is we transport solutes out of the filtrate and water comes along for the ride. Okay, that's the way it goes. We don't usually directly transport water in any active way whatsoever. So what we're going to do with diuretics is we're going to impede that reuptake of things like sodium and or potassium in particular, and that's going to cause a higher osmotic pressure inside the filtrate, and so the water can't follow its a gradient out of the filtrate. So we're blocking reuptake. That's the most common, or reabsorption. That's the most common mechanism that we're going to see when we look at the different types of diuretics moving forward. Just a quick comment for you. When it comes to diuretics and so forth, there are a ton of them out there. There is more information than you could shake a stick at. So what I want to try to do is dial it down to the ones you're most likely to see and try to use a poster child drug for each of the regions that we're interested in. But there's a lot to learn here in each of these regions and a lot going on. We're going to dial this down considerably for the purposes of this class. Fundamentally, when it comes to diuretics, what we are doing is inhibiting enzymatic transport. So we are using compounds that will specifically block protein transporters in the kidney tubule. So we have loop diuretics that affect transporters in the loop of Henle. We have thiazides, which are going to work at the upper end of the loop of Henle and particularly in the distal tubule. And then we have these potassium-sparing diuretics, which work in the end of the distal tubule, but also could extend down into the collecting duct. There are other sites too. For instance, acetazolamide, it's a very, very mild diuretic. We don't really touch this area because it's so hard to control. Acetazolamide is not really used all that much. You know, where the community that uses these the most are mountain climbers. By using a very, very mild diuretic, it helps stave off certain forms of high altitude illness. Another aspect of the kidney tubule is that, before I get into loop diuretics, is that about 2/3 of the reuptake is occurring up here. So if you make even very small adjustments, you're going to end up with a huge amount of change in excretion. About 23%, not quite a quarter of the material that's reabsorbed occurs in the loop of Henle. And so the loop diuretics, even if, again, if you change them just a little bit, they're a little more forgiving. Nevertheless, loop diuretics are very, very powerful diuretics. We don't typically prescribe those at first. Generally, the rule of thumb is that you work your way up from the bottom. You start with the diuretics down here, and if they're not working, and that's one of the issues, is that people become refractory to diuretics, is that they start working their way up or working in combination with elevated levels. But if you've ever heard the phrase, I have to pee like a racehorse, that's because loop diuretics are used in thoroughbred racing in the United States to help dry out the horses, because they run literally so hard they can damage their lungs. And so they give them a drug that we'll talk about, furosemide, also known as Lasix, in order to dry them out to help prevent lung damage during races. Where we see loop diuretics being used is when somebody's approaching a crisis level. If they have hypertension coupled with potential heart failure, coronary artery disease, or they have signs of what's called congestive heart failure, where you start to see fluid building up in the lungs, this is where somebody will get the loop diuretics right away, because they're very, very powerful. Okay. When somebody has true fluid overload, this is where you go to, because you want to get them unloaded, or they may literally start to drown in their own extracellular fluid. For hypertension per se, we're gonna very carefully control it. Again, we're going to work our way up from the distal end of the tubule as we work our way up. And if somebody's refractory to these, then they'll start thinking about low-dose loop diuretics. It is the one that's the easiest to understand, so we're going to start with it first from a mechanistic perspective, and it's basically a sodium transport blocker. Okay. Sodium transport blocker does have some secondary effects of vasodilation, and that's what's really interesting, is that sometimes we see these unpredicted side effects. We know it blocks sodium reuptake, and when you block sodium, the water can't follow, so the water moves downstream to the excretion side. Loop diuretics work in two general ways. On the descending loop of Henle, we have a very, very water-permeant membrane. There are lots of proteins called aquaporins that allow for water to move down its concentration gradient. Now, outside the loop of Henle, in the medulla of the kidney, we have an increasing osmotic gradient. So the further down we go, the stronger the osmotic gradient gets, and more water moves out. On the ascending loop of Henle, the ascending loop is virtually water impermeant. That is to say, water doesn't move, but nevertheless the osmolarity is dropping, and that's because we are selectively transporting sodium using secondary active transport. So we're moving the sodium out. Over here, very, very hard to control because this is a passive process. Over here, though, it's an active process, so that makes it inherently easier to control. By blocking the proteins that transport sodium, you now retain osmolarity inside the tubule, which means it's more likely to be excreted. So here's the wall of the ascending loop of Henle. Those of you who have studied sodium-potassium ATPase, this is the energy input. We pump sodium out, potassium in, we're using ATP right here. Well, the concentration of sodium is very, very low inside the cell. So sodium wants to move through that cell, through this way, and it brings potassium and chloride along with it. It's a form of secondary active transport for these things. It's still sort of primary, but I'm not gonna parse that out too much. So it makes sodium want to move down its gradient from the renal tubule, and loop diuretics, they block that sodium potassium chloride co-transporter, and so the sodium is stuck out here, potassium and chloride, and so water is going to want to stay out here more as well. Our poster child for the loop diuretics is one of the oldest ones. It's often just referred to as Lasix by its brand name, but its technical name or its generic name is furosemide. Again, it blocks that sodium potassium chloride co-transporter, thus retaining water and ions in the renal tubule. The problem, though, is that if you block transport, you're going to lose it. Okay? If you're keeping things in the renal tubule, that means it is more likely to be excreted. There's a formula that says filtration minus reabsorption plus secretion. Well, we're not worried about secretion at this point, so secretion 0. Minus reabsorption equals excretion. And if we're reabsorbing less, we're excreting more. The other side effect that seems to be, it's rare, but nevertheless is something to be mindful of, is that for whatever reason, for reasons that are not entirely understood to us, the loop diuretics do present a risk of hearing loss, diminished hearing capacity. Not exactly sure why. I could have some guesses. It probably has to do with ion regulation. Nevertheless, ototoxicity is one of the more well-described issues with loop diuretics. Ion loss, so ion imbalance, dehydration, because again, these are powerful, powerful diuretics. We're going to want to make sure that these patients are taking plenty of fluids. Probably something that has a little bit of ion supplement in it, tomato juice or orange juice. Not really grapefruit juice, okay? But certainly tomato and orange, things that have minerals and vitamins in them. And then be mindful for hearing issues. Our next category of drugs is a little bit downstream of the loop diuretics, and these are called the thiazide diuretics. That has to do with a functional group found in the molecule. This one is actually the first go-to for hypertension. If we have fluid overload or if we have other issues with ion balance and so forth, we might work a little bit downstream. We'll get to the potassium sparing here in a little bit. Less powerful than the loop diuretic, so it's a little more forgiving. Primarily working in the distal tubule at the top of the loop of Henle, right past the macula densa area. So what we're doing here is we're blocking this sodium and chloride co-transporter. If you remember in the loop diuretics, it actually had three things it was carrying. It was carrying sodium and potassium and chloride. This one is just sodium and chloride, and that's one of the reasons why it's a little bit better for potassium than the loop diuretics is. So we're blocking that co-transporter here. Again, it's sort of a secondary active transport mechanism. But what we're dealing with, though, is because we're not letting sodium in here, we might monkey with some, other ion handling, and that's the primary issue here. Okay? So we're blocking this co-transporter right here. So hydrochlorothiazide is our poster child. It is the go-to category of drugs for hypertension. You still have issues with potassium loss, but because you're not directly moving potassium with the transporter here, it's better than the loops. So that's the primary thing. It's also not you don't have the issue with ototoxicity that you have with the loop diuretics. Our third category, moving further downstream, are what were called the potassium-sparing diuretics. So if you have somebody who has an issue with heart failure, where potassium might be particularly a sensitive thing, this may be the drug of choice. Again, the reason we would use this potassium is because, or potassium sparing, is because we want to try to keep their potassium levels elevated. Find this at the end of the distal tubule, down in the collecting tubule. There are other drugs out here. There are aldosterone receptor blockers and things like that. But we're going to focus again on these potassium-sparing diuretics. What they're doing is they're blocking a straight-up sodium facilitated diffusion carrier type situation. Again, we're moving sodium out into the extracellular fluid here using active transport, and what we're doing is preventing sodium recharge inside the cell coming down its concentration gradient. Since we're not co-transporting anything, we're not affecting potassium or calcium or some of these other ions per se, so you do get a sparing effect because you're not facilitating the retention of potassium inside the filtrate. So it works in the collecting duct at the end of the distal tubule. It's directly inhibiting sodium absorption from the lumen of the kidney tube. Our poster child for potassium-sparing diuretics is known as spironolactone. Spironolactone works by preventing sodium reabsorption. Does not provide for any regulation of potassium. So we can spare potassium, but if it gets too out of hand, one of the side effects that we might see with using a potassium-sparing diuretics is that it works too well, and now you've lost your homeostatic mechanisms for potassium down there in the distal tubule and collecting duct. And so now, instead of having enough potassium that you want to keep around, now you've kept too much. And that can lead to CNS issues. It can lead to muscular weakness and tremors and so forth. There's lots of possibilities when you have too much potassium. Cardiac arrhythmias. The general therapeutic concerns regarding diuretics are, first of all, dehydration. Anytime you're taking a diuretic, it is a good idea to reassess the patient's fluid intake and balance it so that they are not accidentally dehydrating themselves. The general signs would be lethargy or what we call orthostatic hypotension. That's that dizziness if you move too fast. If it starts to get particularly severe, that means that the drugs are probably working too well. And in the short term, the best thing to do is increase their fluid intake. Ion loss of regulation, particularly potassium, and that's with diuretics. Now, on the other side, if you're using potassium-sparing diuretics, the overload of potassium is potential an issue. Potassium deficit can be, as well as overload, can be a real problem. The anagram is sick waltz, shallow respirations, irritability. That might be something that isn't as noticeable, especially in an older person. Confusion and drowsiness, they may be written off, so you want to keep your eyes if you see any significant mood changes. Sick waltz, so SIC, shallow, irritable, confused. Weakness, arrhythmias, lethargy, and thready pulse are all signs of a potassium deficit or perhaps even a potassium imbalance. If they have hyperkalemia, they may be also irritable. Why? Because potassium is involved very much so in nerve function, muscle contraction, and cardiac function. So we do see arrhythmias, dysrhythmias, irregularities with deficit or overload. We do see GI issues with deficit or overload, and certainly CNS with deficit and overload. So it's that homeostatic window that we want to be in between too little and too much, or we actually see some of the same syndromes. So we have issues potential with muscle weakness and cardiac and nerve function. Well, there's also this sort of idiopathic scenario with diuretics, and that is that it may affect your glucose and lipid handling. So you may see hyperglycemia, hyperlipidemia. So keeping them active, keeping them engaged, and looking for changes can be part of the strategy for someone who is taking diuretics. Well-balanced diets, critical. High in vegetables and fruits, high in vitamins and minerals to deal with certainly the ion dysregulation, but also the hyperglycemia and lipid regulation. So we had a pretty big section there dealing with modulating the excretion of fluid in the renal function there. Lots of mechanisms, considerations. Don't make sure that you're spending the appropriate amount of time getting down those key points. What we're going to do now is move to another organ system. This time we're going to move to the heart in the form of what we call beta blockers, beta adrenergic receptor blockers. And so, yes, beta blockers blocking the beta adrenergic receptors, causing reduced cardiac output in the form of slower rate, slower force of contraction, and yes, maybe the AV conduction. We're not really going to go there all that much. If you ever see the drugs that say OLOL, that's what we mean by beta blockers. Side effects, though, down here. So this is a nice overview slide. I love these little cartoons like this because they help us get started and help us retain information that we've covered sometimes rather quickly. Beta blockers have enormous potential therapeutic activity with the caveat that there are occasionally side effects for them. But beta blockers have indications in things like chest pain or cardiac arrhythmias, glaucoma of all things, hypertension, and that's where we're going to fit in here. The theophylline overdose I'll explain here in just a second. But let's dial down on beta adrenergics for just a moment. Beta 1 specific blockers are going to be the ones that affect the heart. That's because the highest proportion of beta adrenergic receptors is found in myocardial tissue. Beta 2, on the other hand, is found in the lungs. And so that gets us to the theophylline overdose. Theophylline is found in many things and used as a bronchodilator. Though if you get an overdose of theophylline, you may end up with side effects secondary to sympathetic agonism. It's a beta agonist, but it's also relatively non-specific adrenergic agonist. So if you have a theophylline overdose, one of the things that might happen is you might end up with damage to the lungs because you're inhaling it and so forth. And so what we could use is a beta 2 would help protect the lungs by increasing secretions in the lungs. Helping prevent the lungs from drying out or getting damaged because of that dry out. So that's why a beta blocker in that situation may be beneficial for theophylline. Our poster child for the beta blockers, in this case, since we're interested in hypertension, we're going to use atenolol, which is a cardioactive drug, among other things, but it can be used secondarily to help lower blood pressure. Given what we've covered up to this point in class, then a beta blocker should make perfect sense from the fact that we would reduce blood pressure by reducing cardiac output in a general sort of anti-sympathetic activity situation. The unpredicted side of this, the idiosyncratic side, is that these beta blockers seem to also block renin secretion. That is to say, they will slow down the release of renin from the kidney, which means less angiotensin II, less aldosterone, and more excretion. Aldosterone causes water to be retained from the kidney filtrate by transport of sodium. You put more sodium transports on the surface of the kidney tubule, you pull more sodium out, pull more water out, you retain fluid. So the renin, by blocking it, means that you're going to excrete more from the kidney than you would before. And that's the real point. Above and beyond the indirect lowering of blood pressure, you can also affect this hormone system that has an effect on blood pressure through fluid retention. The side effects and ADRs of beta blockers, first of all, are generally when the drug is a little bit too effective, if you know what I mean. So low blood pressure, hypotension, slow heartbeat. drowsiness, sometimes depression, but the serious one, the one we're going to want to prioritize, is these symptoms of heart failure: coughing, shortness of breath, edema, fatigue, exercise intolerance. So things like labored breathing, which would indicate that that fluid is beginning to accumulate in the lungs and they're not getting enough oxygen to meet metabolic need. Coughing, same thing. This is collectively known as dyspnea. Peripheral edema, so that's when you start to see swelling of the hands and especially the ankles and the feet. Something called jugular vein distension. What's happening here is that fluid is starting to accumulate in the lungs, and so they're starting to get a fluid backup. And this is what it looks like. You start to see pronounced distension of the jugular vein right above the clavicle there. But low blood pressure, slow pulse, more chronic symptoms, weight gain, or lack of urination. But this is the one that you'd want to have more immediate type of a treatment because this one's the most life-threatening. Okay, now that we've talked about the beta blockers and cardiac output, now let's talk about vasodilators and lowering peripheral resistance. So the mechanisms that involve vasoconstriction, vasodilation, is a huge area of ongoing research. So we really can't get into all of these possibilities, but the four standard ones we're going to go for include the nitric oxide donors, nitrates. We have the calcium channel blockers, we sometimes call those CCBs. And then we have ACE inhibitors and just a little bit about angiotensin receptor blockers because these are all in the same basic pathway. These other ones, not really going to talk about a whole lot. Many of these are still working in progress and there's a lot going on here. In the families of drugs that are vasodilators, we have some that are called direct acting. There are actually two subfamilies of this direct acting vasodilator. First we have are called the nitric oxide donors. So the NO with an extra electron. This is a free radical. It's got an unpaired electron that makes it very, very reactive. It's also very, very lipophilic. So when nitric oxide is released from cells in a given area, it will diffuse rapidly across membranes in virtually every direction. So a nitric oxide donor, like for instance this one right here, or nitroglycerin, what we do is we increase the concentration of nitric oxide. This turns on an enzyme that creates a second message. That's a cyclic GMP. We can break down cyclic GMP with another enzyme to shut this down. That's called phosphodiesterase, where we abbreviate it PDE. In either case, if we're increasing NO or we are blocking PDE, the response is relaxation. So nitroglycerin would be an example, or nitroprusside, that's what this is right here. These will all contribute to increase cyclic GMP by adding nitric oxide. PDE inhibitors will block the breakdown of cyclic GMP, and sometimes these guys are used in combination. By the way, a very famous PDE inhibitor is what we use for hair growth. We call that Rogaine, and we use basically the same active drug for Viagra, because the mechanisms for vasodilation help contribute to growth and also can help contribute to sexual function. So pretty interesting stuff. But you don't want to mix these things too much. Sildenafil is the generic name of Viagra. In any case, the side effects for both are headache. Because you're dilating blood vessels in the cerebral vasculature, that seems to drive a headache. One of the theories of migraine headaches is excessive vasodilation in the cerebral circulation. That's the most common situation. There are some others, but that's the most significant. Another class of drug that is involved in vasodilation are known as the calcium channel blockers. So you're blocking the ability of calcium to move in from the extracellular fluid. We're not going to spend a ton of time on this one. Why? Because we're going to talk about it when we get to cardiac agents. What happens is that calcium moves into the cell. It will activate smooth muscle contraction in the vasculature. And then that leads to, so if we block that calcium, then you don't have smooth muscle contraction. So, the blood vessels vasodilate. The problem though is if you add a calcium channel blocker, you get cardiosuppressant, just like with a beta blocker. So reduced blood pressure, slow heartbeat, may precipitate an issue with conduction in the heart. The vasodilation can cause, like before with the nitrates, headache. Because you're dealing with smooth muscle in the gastrointestinal tract, by blocking the calcium channels, you don't get the normal gastrointestinal function, and it may contribute eventually to edema because, again, the dilation of the vessels. And here again is the renin-angiotensin-aldosterone system. Just a little thing to help you remember what this is doing is that we have angio, which means blood vessel, and tensin, the tension, if you will. So if we have increased tension in the blood vessel, that means we would have increased pressure. So what renin-angiotensin-aldosterone system is doing is causing an increase in blood pressure. Don't forget the steps here. We have angiotensinogen, that's made by the liver. When the kidney senses low perfusion, low blood oxygen tension, it will start to secrete the molecule renin. Renin converts angiotensinogen to angiotensin 1. Now, angiotensin 1 doesn't have any known biologic activity. People have suspected, but not yet identified it. But as angiotensin 1 moves through the bloodstream, it will go to the lungs, like all blood will, and it encounters ACE. ACE will convert angiotensin 1 to angiotensin 2. Now, angiotensin 2 does have significant biologic activity. Angiotensin 2 has at least 2 different types of receptors. Like the adrenergic receptors, they are tissue distributed. And one isoform of the angiotensin 2 receptor is found in the blood vessels. So we can target that one, and that will still retain maybe some other activity for angiotensin that we might want, but getting after the blood pressure. So in summary, we have the ACE inhibitors, which are going to block ACE, preventing angiotensin 2 from being created. And we have the angiotensin receptor antagonists, or the angiotensin receptor blockers. They're going to work, hopefully, right here at the level of the blood vessel, targeting a specific receptor. And again, the more specific you are, the less potential for adverse or unwanted side effects due to other processes. I've shown you the angiotensin receptor figure a number of times, but this is the stick figure version of it. So if the other ones aren't working for you, you've got a lovely figure here. What I like about this figure is that it shows 2 of the known isoforms, AT1 receptor and AT2 receptor. Most of the angiotensin receptor antagonists are going to go after that AT1 because it's the one that has the effect on blood pressure. That's what pressor effects means. So ACE inhibitors, we call those, most of these drugs in this family have been given the last, the end of their generic names, pril, perindopril, quinapril, enalapril, and so forth. Those are all hallmarks of ACE inhibitors. These guys are extremely common in anti-hypertensive therapy. So anytime you see a pril, you're going to think ACE inhibitor. Very, very common. Like I said, as of when I created this PowerPoint, there were at least 10 different drugs out there. And then we have the ARBs, and you've already seen from our lab last week losartan. It's an angiotensin receptor antagonist. And you can see the ARTAN family here as well. Again, very common. ARTAN, 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 and so forth. Again, to indicate that they are angiotensin receptor antagonists, ARTAN, angiotensin receptor antagonists, or refer to them as ARBs. The therapeutic concerns with ACE inhibitors, ARBs, is not dissimilar from what we see with the diuretics, dehydration and low blood pressure, hypovolemic situations, orthostatic hypotension, ion depletion, in particular potassium. Again, very, very similar to what we've seen with other diuretics. Now, ACE inhibitors in particular do have some non-specific situations, rash and then a dry cough, of which about can be so severe that people have to withdraw from the medication. That's because it's affecting, and I'll show you a figure here in a second, the bradykinin system, and it's causing irritation. A few people will get angioedema, that's basically swelling underneath the skin. You'll particularly manifest in the hands and distal appendages. But here's the where the ACE inhibitors often have this side effect. It's right here, bradykinin. It leads to a blocking of appropriate signaling and so forth in the lungs, leading to this dry cough. And I'm wondering if it's something along the lines of what we're seeing in COVID, because COVID will bind ACE in the lungs, and we're seeing a dry cough. It just makes me wonder if there's a connection there. Really, really interesting if that's true. Here's one of those fun cartoons that talk about the ACE inhibitors. Ends in pril. Okay, we're getting rid of vascular resistance, but here are the side effects. These are the ones that you're going to want to pay attention to. The book also gives a little bit of lip service to plasma renin inhibitors. This should make sense. If you block renin, you're blocking the creation of angiotensin 1 upstream. It implies that it could be a little more powerful, but we just aren't there yet. It's a work in progress. Now, these pages right here, 78 and 79, are ones that I would ask that you emphasize and make sure you take good notes when you're doing it. Antihypertensives, the issue is that you may have too much hypotension, and that makes them have exercise intolerance, not enough cardiac output. Exercise intolerance means they just can't keep up. They can't catch their breath. They can't exercise to any significant degree because their body just isn't meeting metabolic need. Either the heart or the circulation just not there. Other symptoms of hypotension, dizziness, fainting, dehydration, there's lots of possibilities here. Again, be able to recognize those things should all make sense from a physiologic standpoint. There are issues occasionally with glucose and lipid control. Because these patients are often experiencing other things that alongside their hypertension, polypharmacy is an issue. And so you can see common combinations in here, beta blockers with a diuretic and an ACE inhibitor, all sorts of fun stuff, a blood thinner. It can get crazy real quick. And so with patients that you're dealing with on this level, polypharmacy does start to rise to the top. And so that completes chapter 6. Again, if you're looking for guidance on where to pay attention, look where we spent time. Look where I showed multiple images of the same process. Look where I drilled in. If I was superficial, look what I pointed out in those things. Take good notes and look for where the points of emphasis are. Cross-reference those points of emphasis in the book. So use the book to help fill in or look at the material from a slightly different perspective than I present it. You see what I'm talking about? Go find where the book is talking about it and see how those things overlap. That's the key. My lectures are not a replacement for the book. They are an augmentation for the book. So look for where we're spending time. Spend more time on that in the book. Good luck, and I will talk to you soon.